Welcome to the Colorado Cancer Screening Program annual meeting. I'm super excited for all of you to join. I'm Andy Dwyer with the University of Colorado Cancer Center and Colorado School of Public Health. And I also help advise Fight Colorectal Cancer and a number of their colorectal cancer and research aims. I'd love for all of you, if you can use the chat feature, to go ahead and write your name, your organization, where you're hailing from today. If there's anything specific that you'd like to know related to the cancer prevention topics we're going to be covering today, related to colorectal cancer, lung, and hereditary and genetic cancer, as well as looking at part of the research aims and portfolio moving ahead for colorectal cancer, it'd be great to have that information. So while we're getting folks on, if you can add that information into the chat. Elsa, as we're just getting our final folks in play, any specific audio visual instructions today for those who are joining?
Yeah, thank you, Andy. Hi, everyone. I'm Elsa Weltstein, Program Manager for the Colorado Cancer Screening Program. I'm on along with Rena Solar, our Program Coordinator. If you have any technical issues, you can message either of us for support, and you are all muted at this time, but we'll have the opportunity to come off mute when we do a short meet and greet later, as well as for Q&A. And I've also enabled subtitles. So if you would like to turn those on or off, you can click the little arrow button next to live transcript and hide or show subtitles. So thank you all for joining, and please engage with us in the chat, ask your questions, and add to the discussion.
All right, amazing. And I want to thank Elsa and Rena for all the dedication and support to get today underway. As many of you know, we typically have the CCSP annual meeting in person. We try to bring in partners from throughout the state, but we're continuing still in the virtual mode for the next probably 6 months, but hopefully next year we'll be able to join in together in person. So I'm excited that we have a great lineup today in terms of subject matter experts, advocates who are joining us. We have some great opportunity, I think, to focus on colorectal cancer as part of the cornerstone of our statewide program that focuses on cancer prevention. So CCSP is now so much more than colorectal cancer and navigation efforts. It is looking at a longer trajectory in terms of inclusion of lung cancer screening, hereditary and genetic cancer screening as well, and looking at stronger alignment with our breast and cervical partners into cancer prevention and control from, again, a larger sort of prevention mode. Not thinking of body part, but really thinking about integration of whole person cancer prevention. And that's really been the name of the game. So you'll see today our lineup of speakers definitely represent that. I'll have an opportunity to share some recognition awards that have been actually established at the national level with one of our partners, the Public Community Health Center, talk a little bit about our statewide screening program, the state of colorectal screening in Colorado and nationally. We'll have a chance for Melissa Gilstrap to share a little bit about the state of hereditary and genetic cancer, which aligns with much of our capacity building work. We'll have time for Q&A, and then we'll also have a bit of time for meeting your neighbor, some one-on-one stretch break as well. And then in the second part of the meeting, we'll also have a state of lung cancer screening from Dr. Debbie Dyer, who's been a partner with us with CCSP as well. And again, in the spirit of really focusing on March as CRC Awareness Month, we have Dr. Richard Goldberg, who is a medical advisor for Fight CRC and a longstanding cancer champion and expert, to talk a little bit about how we're also looking at research strategies and where we're moving in terms of really thinking about addressing colorectal cancer as a whole, related to some of our strategies working with Fight Colorectal Cancer. We'll have time for Rich and Debbie to have the Q&A portion at the end of the show as well. So all you cancer enthusiasts, welcome. There's definitely something for everyone today. And again, in the spirit of collaboration and partnership with so many of our FQHCs, rural health clinics, and safety net clinics at large, thank you so much for the great participation, and glad to see that we're now over the 50 participants who registered for today. So with that, I am actually going to turn it over to actually share part of this recognition and celebratory work that I mentioned with one of our great partners. Let's see if my slides will cooperate. In terms of working with Donald Moore and the Pueblo Community Health Center, they have been acknowledged and recognized as the grand champion of the National Navigation Roundtable work in terms of looking at increasing of colorectal cancer screening rates, and really with a devoted lens around health equity. We are thrilled that Pueblo Community Health Center is one of our leading health centers in the CCSP work, and we're really excited that Colorado and one of our partners had an opportunity to be recognized at the national level. So Don, I will turn it over to you to share a little bit about this word, and I'll offer up again a huge warm congratulations. So Don, I'll turn it over to you.
Thanks, Andrea. I'm honored to be here today to represent PCHC. The first thing I want to say is just to congratulate everyone on the call today for your efforts at this important public health improvement initiative to which we're all a party. I'm honored to be here. Yes, we were recognized, but I kind of feel like our accomplishments are really just emblematic of everything that all of us are doing. Certainly, I'm proud of my organization for being recognized, but humble enough to realize that these kind of improvements are being made all over the state. And so hats off to everyone. Andrea asked me just to mention a couple of things that were critical to us making our improvements, which going back to 2018, our screening rates were as low as 51%, and we've, as the slide shows, increased those to 62%. I'm sure everyone realizes that these improvements are made over the long run, so I am going to really condense, in the interest of time, the things that work for us and not get too down in the weeds. I'd be glad to answer questions later in the agenda if that's appropriate. But first off, we established a senior leadership commitment to the improvement. We set it as a priority. And as our teams did their work, we ensured that there was promotion of the initiative, recognition of improvement, and that we communicated it thoroughly through various mediums within our organization and external to our organization. A second thing I think we did well was around our data program and measurement. We measured this at all levels of the organization, including reporting to our board. We had a clinical quality oversight committee that tracked our progress monthly. It was integrated into our clinical staff peer review process. And we benchmarked ourselves to our peer community health centers in Colorado and nationally. And that helped us stay focused. The next thing that we did was we really used the PDSA cycles. And I know everyone here is familiar with that approach. Some specific things we did is we designated a bilingual case manager. We did extensive training with our medical assistants. We adapted our workflows to telehealth. And one thing that we did that I think really stood out is we identified 2 of our PCPs that were willing to be champions and really take on the effort of revising their workflows and focusing intensely on this so that we could learn what works and what doesn't work. And then from their lessons, we spread those across the whole medical staff. So leadership commitment, measurement and data, and fidelity to the quality improvement process, PDSAs. So in terms of the impact, you can see the gains we made. We're still well short of the 70.5% that Healthy People 2020 set, and the National Colorectal Cancer Roundtable wants every community to be at 80%. So we have more to do, and we're going to stay on the path. But we in 2018, I think we're among the bottom 5 of 20 community health centers in Colorado when we benchmarked ourselves. Now we're regularly in first place or second place, if that's the right way to put it. So thank you again, Andrea, for inviting me. I want to keep it short because I know you have a busy agenda. So hopefully that's helpful.
Absolutely. And Don and team, and I know with Linda, Don, so many of the folks at Public Community Health Center, you guys have been just amazing partners over the years, and we commend you. And I really think those lessons learned are fantastic. And I think we might continue to showcase our partners who are doing great implementation and have continued, I guess, advice, ideas, and lessons learned in this process. So congratulations, Don and team. We're going to go ahead and move into our work right now, speaking around colorectal cancer specific. I'm excited on behalf of my team to present information about the state of colorectal cancer in Colorado, as well as the state of the CCSP program. And then we'll go ahead and continue on with, again, a number of our subject matter experts. And so I think most folks around the table are clear that the Colorado Cancer Screening Program really did start as a specific program specifically dedicated to colorectal cancer screening in 2007, when we received the first award from the CCPD grants program at the State Health Department. And then by 2013, with the shift into ACA, we continued on the colorectal cancer path as really our priority. But really, we focused much more on the patient navigation, barrier reduction to care, as ACA did allow for much more medical access service, which was great for our team. But again, in terms of looking at an evidence-based intervention that really does improve access to care, reduce barrier reduction, navigation remained the name of the game, because there currently, and even at that time, of course, wasn't a reimbursement mechanism. So we're really excited that we have been able to expand this work into our lessons learned into colorectal cancer, into lung and hereditary cancers, thinking about navigating into whole person preventive care. And a lot of our lessons learned and work really did build off of the work that was happening at our state health department with the Women's Wellness Connection, now also known as the Cancer Prevention Early Detection Work, CPED at the state health department. So I just want to say it's been fantastic, the dedication, support from the CCPD grants program. We've oftentimes had great and actually maintains great partnerships with the American Cancer Society, our FQHCs who are participating, World Health Clinics, the state health department, and a number of entities all throughout the state. So I want to just say thank you and acknowledge, that we've been one of the longest standing preventive cancer screening programs with colorectal cancer at the helm. But our idea, I think, here in Colorado would be to really look at how do we look at those most preventable and lethal cancers and look at whole cancer prevention. So in terms of looking at our specific goals, we really do want to think about how the cancer rates in Colorado, how we're dedicating resources to look at those rates improving, particularly around the medically underserved, those with who lack access to care. We want to continue to keep our pulse on the NCCRT, as Don mentioned, the goal set up by Healthy People 2020 and beyond, the 80% in every community. Going to be continuing to look at the work around lung cancer and hereditary and what those benchmarks. And again, that huge fostering partnership and really utilizing patient navigation have been the name of the game. So again, I think the implementation of the family history screening, lung cancer capacity building, and then an area that I haven't focused on as much, but I've mentioned, is really looking at that sustainability of patient navigation and the workforce development work in that area. That is something that we're definitely devoted to as well. I'm going to commend our state health department, who has created an opportunity for workforce development with their registry, their assessment, looking at paths to sustainability for navigation. We've been involved at the state and national level with a number of agencies to really look at stronger reimbursement and really thinking of role definition, workforce development, so that we can make navigation a mainstay and something that isn't only reliant on state and foundational funds and grant funds. So I just want to say this is a huge part of what we're moving to in terms of also that endoscopic screening, navigation into colonoscopies, and really building that stool-based testing capacity as well. So we've got our work cut out for us. We did receive a 2-year extension from CCPD last year. So we will be sunsetting officially in June 2023 with that funding source, but we will be looking at opportunities to continue our infrastructure moving forward. So we're excited again to be really involved at the state and national level, working with many of our partners, but I think there's still a lot of work to be done. We ultimately know that in Colorado, even based on 2019 reports, there are nearly 20,000 colorectal cancer survivors, but it's estimated that there's over 2,100 people who will be newly diagnosed each year and over 700 people who will die from the disease. Unfortunately, we know that late-stage incidence is remaining stable, but ultimately, this is translating to a number of the folks being about 60% of those diagnosed are stage 3 or stage 4. So those are some of the really grim things that I think we need to work on in the state is understanding of signs, symptoms, family history, and understanding what puts us at risk, but also really thinking about population-based screening and how does that really help us really think even finding cancer at an earlier stage or ultimately preventing. So interestingly enough, from 2014 to 2018, we're also seeing a slightly higher increase in the deaths in men versus women, which both have been, it's usually and typically often referred to as an equal opportunity killer, where men and women are about equal. But these are the types of trends that we're keeping track of for sure, and specifically looking at the high burden of colorectal cancer in those who are Black and Hispanic Americans, and who are served again from our priority partners, which are the FQHCs, rural health centers, and again, the safety net partners at large. So we still have a lot of great work to be done. We're making great gains. What we do know about screening is that overall, we've increased in the overall population from about 67% being screened to about 74% being screened by 2020 for those who are 50 to 75 years old. This is essentially looking at colonoscopy, stool-based testing, all of the screening modalities, but this is a huge win in Colorado. So we're not at that 80% yet, but we're getting darn close. The good thing is that I think those who are using insurance, Medicare, those are really driving up those numbers. But as Dawn mentioned earlier, the FQHCs and rural health centers oftentimes have numbers that are well below these high 70, almost 80% rates. We also know that in terms of looking at BORFIS data, that those who have less high school education, those who have less than a high school education compared to college have higher screening rates. We know education makes a difference. And we know that those with higher incomes ultimately have a greater rate of being screened as well. So this is huge in terms of really thinking about the access, the outreach and awareness for those who lack access to education, who are formally educated, as well as those who have lower incomes. We also know, as been noted in terms of looking at that burden of death and disease, as we know that the screening rates are substantially lower for Hispanic Americans and Black Americans as compared to white Americans. And so this is something that I think we're also seeing in Colorado, and an area that we're continuing to look in terms of that health equity lens, and where navigation makes a huge impact. So there's a number of disparity information. We know that even for colorectal cancer right now, that the disparities amongst those who are African Americans, Indigenous folks, as well as Black Americans, even for colorectal cancer, the disparities are actually higher in colorectal cancer than cancers such as breast cancer. And again, I think that the breast cancer community has done an amazing job of setting a precedent of how to build strong cancer prevention programs. And that's a model that we need to continue to leverage and utilize in terms of thinking about approaches, and they are a great success in funding sustainability. So I'm just going to move forward to talk a little bit that again, in terms of working with that response to this work, ultimately we know that focus on medically underserved, so the FQHCs, the rural health centers that we work with, those have been the touch points for a lot of CCSP work. And right now, essentially we know that ultimately, nationally, the screening rates between 2016 to 2020 were nationally amongst FQHCs 42.33% in terms of the national, but in Colorado, we're only about 48%. So we still are lagging a little bit behind what the FQHCs are doing at the national level. And so that's why so much of the work that I think has been devoted to FQHCs and rural health centers is really needed to be continued to be prioritized and focused. And that ultimately we know from the FQHCs that FQs right now have a screening rate about 18% of their population to up to 61, which Don, shared that he was actually on the higher end of that. But so many of his partners, those who are in the field, are still well below 20% of their population being screened. And so what I want to just advocate is that in Colorado, I think we need to make colorectal cancer screening still a priority for our funding, for our legislature, and for many of our health partners to understand that this is still a critical area we need to focus. We also know that those who have lower incomes utilize stool-based testing on a much more frequent basis than those who have private insurance, which again, the best screening test is the one that gets done. But when we really think about this access, we really need to be really thinking a little bit about who's utilizing these forms of testing, what are the different types of support in terms of return rates, annual adherence, and how are we really making sure that people have responsible screening. I'd like to share a little bit of data that I think is also much on the radar of many, is also really looking that while we've had great gains in terms of looking at colorectal cancer mortality, which is that top row, and we really think about where we're going, those who are 50 to 64 years old, as well as those who are 65, you'll see that ultimately the mortality rates have gone down. And of course, that's an added artifact of the cancer screening rates really going up. And that's because of the guidelines really indicating up to a couple of years ago that those 50 and older need to be screened for colorectal cancer. Therefore, we see that mortality trend going down. But part of the interesting thing that's happening is for those under 50, where, of course, that ACS guideline has moved from 45 to 50 now, and that takes care of part of the population that we're seeing as younger increase. Ultimately, we are seeing more younger people being diagnosed with colorectal cancer at a rate that we've never seen before. And so while, again, the cancer screening guidelines moving from 45 to 50 will really help take care of some of that, increase and help hopefully reduce that cancer mortality, finding cancers earlier as well. Their guidelines currently for population-based care do not speak to those who are under 45. There are recommendations for those who have hereditary risk, which Melissa will talk about, family risk, personal risk, additional types of syndromes, management of signs and symptoms, but largely we oftentimes don't know what is driving this increase in those who are under age 50, under age 45. And that's a really scary topic and something that we're going to be spending more time. And I believe Dr. Goldberg will be addressing that as well. But, I want to just focus that ultimately this has to be something that colorectal cancer is prioritized as a priority moving forward, because even based on some of the recent data by JAMA, other contributors, by 2030, colorectal cancer is expected to be the leading cause of cancer death in those in 20 to 49 years old. In the year 2030, even alone, it's estimated that 24,700 people under the age of 50 will be diagnosed with colorectal cancer. So again, really thinking about the research, the etiology, understanding what this means for screening, on-time screening, as well as really assessment of families, as well as those who are at high risk for a number of reasons, is going to be essential for our work moving ahead. I just want to also state that, the health department has done a grand job of really helping create some great visuals. I know that we have some great work with our cancer control program partners. I believe Ian, several of our folks from CDPHE are joining, and part of their team have really created some great graphics to really showcase what's happening within Colorado. And just to kind of give a taste and a flavor, essentially when you're looking at this map, the darker color the region, ultimately the later stage disease we're seeing, the smaller the dot, the lower the screening rate. If it's smaller and a darker color, the greater a screening rate, then ultimately, is ultimately a dot that has that yellow. Looking at the etch centers definitely show where we have ultimately indication of what the population and the poverty level look like. And ultimately, we really rely on the data of so many of our partners to help us understand where we're resource and prioritizing resources all throughout the state. So I just urge all of you, as we continue to put data out for your planning, for the work that you're doing, advocating for colorectal cancer, having conversations with your community, this data is going to be key. And this is information we utilize as well in much of our work. And I think I mentioned this previous, but I just want to say, congrats to a number of those groups who are really looking at reaching that 70 to 80% of screening. It's been a long haul. It's been something that many folks have dedicated great time and energy to. But we also know that there's a number of organizations and different demographics who fall short of this kind of screening rate, reaching that 70 and 80%. So ultimately, those who are uninsured, overall 50 to 64, looking at people who are Hispanic as well as people who are rural and frontier communities, we're not at that level yet. And again, I think that's a whole ode to the work that's happening with the medically underserved and keeping these rates so we don't leave folks behind. The best screening test is the one that gets done and gets done well, but equity and access is going to be critical. Having that said, those who are insured, those who have CMS, those who are 70 to 75, we're doing a grand job of really reaching these screening rates. And I think there's a lot to be said for utilizing those resources to make sure that we are getting close to that 80 or 100% screening compliance. So again, let's use that data. Let's really think about our entire Colorado cancer community for cancer prevention and control in general, and for colorectal cancer. I'm just going to quickly mention that, one of the things we've been able to do is implement the CCSP program. We've had almost 35,000 people screened, navigated into screening. We have great outcomes. We know people are showing up. We know that we are reducing in preventing cancers. We know that we're showing great quality when they utilize those endoscopic screening, and that we know that we're preventing cancers as well. And even if you look at what it would have taken in cost in terms of treating cancers versus the time and money spent in this program in preventing, we have great cost estimates to show that we're well ahead of the investment in terms of cost savings, even with the estimated that we have about 12 to 15 million that we would have saved the healthcare system, as well as ultimately quality of life in individuals if they would have otherwise been screened. So I want to thank Elsa and the team and many of you who submit data to help us make this case, but I think the devil's in the details. In part of the closing, I just want to mention that we have to be responsive to COVID. I think for breast, cervical, colorectal, many of the cancer prevention types of interventions, we're behind. We have that pent up demand and need. We ultimately know that colonoscopies were down. There's an estimated number of new cases. We're doing that current demand in terms of those who are age eligible based on population screening, but we also have that 2 to 3 year backlog. We're taking this very, very seriously, especially for the medically underserved community. And ultimately, since that ban has been lifted, all of our navigators have gone gangbusters in terms of trying to make sure that we have capacity to make sure folks are screened and to really look at this pent-up demand. And again, I just want to say in closing that we are really looking forward to some opportunities to continue the work. We've had a very supportive legislature who's helped really think of access to care bills, bringing March as Colorectal Cancer Awareness Month. We want to really stay engaged to make sure colorectal cancer stays as a topic, reduce that stigma, continue the work. But again, I think making sure that we're really thinking about holistic care and how are we really thinking about prevention for the whole person and really thinking about stronger connection with the partners and resources that have already been established within Colorado. So I know we're going to have Q&A next, but I am going to go ahead and stop sharing right now. And thank you guys so much for the time and the dedication. And I think Melissa is up next. Is that correct, Elsa?
Yes. Melissa, you can go ahead and bring up your slides. Awesome. I can see them in full screen. So we're going to pass it over to Melissa Gilstrap, who's a genetic counselor at Centura. And then following her presentation, we'll have Q&A. So please put in your questions for the colorectal cancer screening work as well as Melissa's presentation, and we'll answer all of them at the end of her section. So thanks, Melissa. I'll hand it over to you.
Thanks so much. Let's make sure we can get these moving here. There we are. All right. So yes, I'm Melissa Gilstrap. I have worked for Centura my entire career, and I'm based at Parker Adventist here in Parker, Colorado. Most of my patients are coming in for cancer risk assessments, and I'll be giving you kind of the Centura experience and some of the things we're seeing that are very exciting in the genetic counseling field from our Centura perspective. And these are my people. So before we get started in some of the top 5 things that I think are really exciting going on, I think it's important to really take a step back and say, why is genetic counseling important? And I think Andy really highlighted one major thing, that when we prevent cancers, we save the healthcare system a lot of money. Yes, we save the healthcare system a lot of money, but we also prevent a lot of quality of life issues, mortality, morbidity for our patients. So we get the right care to the right people at the right time, and we can prevent cancers or lead to early detection, which really makes a huge impact on our patients. All right, so these are the top 5 updates I'm going to go through in only 10 minutes. There's not a whole lot of deep dive you can do, but I really look forward to your questions and seeing what this brings up for everyone. So one of the biggest changes we've had recently in genetic testing is that we no longer have to do a separate test for every single gene that we're interested in. So we're able to utilize a development called next generation sequencing to look at every single gene that we're interested in one test at one time. And that's really allowed us to be able to detect more rare syndromes and get full coverage of all hereditary cancer syndromes for each patient. We've had some unexpected findings. We're realizing that maybe colon cancer is part of some breast cancer syndromes and vice versa, because those individuals hadn't previously been tested before for the colon cancer syndromes, for instance. But really the biggest implication is for our individuals who have previously been tested for just BRCA1/2 mutations or just Lynch syndrome. It really is time to update their testing and make sure that they've been given all of the appropriate coverage for the different genes that we know are related to various cancers. Number 2 would be our guidelines. Our guidelines are ever expanding who qualifies for genetic testing. There's lots of different guidelines out there, but the most commonly used in the genetic counseling world is the National Comprehensive Cancer Network. And their updates over the last few years have really made it so almost every single cancer patient qualifies for genetic testing. Almost all breast cancer patients, all ovarian, pancreatic, and metastatic prostates, and then colon and uterine cancers diagnosed before age 64. And individuals who haven't had cancer themselves, but have a family history of anyone who meets those criteria are able to get genetic testing from these guidelines. And this is really what a lot of insurance companies look to design their coverage policies. So if you're not looking at NCCN and you have patients that you're evaluating to see, is this someone who would be appropriate to refer or not, I highly recommend that people make a login for free at nccn.org and just take a look at these guidelines periodically, because they are being updated regularly. And something we talk about in our centers is really the list of who wouldn't you test is getting really, really short. So I think as we are moving forward, we're going to need to start preparing for being able to test all cancer patients and all individuals who are interested in hereditary cancer testing, which that sounds overwhelming at first, that, ooh, that's a lot of people. But if you think about the impact that could create for not only our cancer patients, but for their family members with that downstream cascade testing and the cancers that could be prevented, that's our eye on the prize that we have to figure out how to deal with the volume to get that wonderful benefit of that impact on our patients. And then, as I alluded to, insurance coverage following those NCCN guidelines is really better than it's ever been before. There are mandates in the Affordable Care Act regarding BRCA testing and genetic counseling for BRCA mutations that make that type of counseling and testing considered a preventative service with no cost sharing, which has really been wonderful for many of our patients, but not all. In my ideal world, there would be a mandate covering any type of hereditary cancer genetic counseling and testing. Insurance policies again, follow NCCN guidelines and really have become pretty clear in most cases, and easy to follow to make sure we know we're getting appropriate testing and that it's going to be covered. Some labs do require extra paperwork or genetic counseling prior to testing. Some insurance types, I should say, require that extra paperwork. But many of our labs have self-pay rates that they've developed for patients who aren't quite meeting criteria, but are still very interested in this testing. So it is accessible for folks who would like to get more information, even if they don't quite meet criteria. And then thankfully, many of our labs offer low cost or free testing to the individuals who meet criteria, but who have no insurance types as well. So what I'm always telling my providers is, if you think it's appropriate for a patient to be seen and possibly tested, send them my way and we will figure it out. We have avenues for appropriate testing, even if there's a cost barrier there. We can find options. And then many of our labs are doing those insurance authorizations for the providers, to make it, again, easier for appropriate people to be tested and to take away that barrier of time to do those authorizations. But one big problem here is that Medicare still does not cover genetic counseling. They cover the testing for appropriate patients, but they will not cover genetic counseling. And I'll have a little something that we can do about that closer to the end. And then virtual care, that's number 3. That has really been the silver lining of the pandemic. I know here at Centura, within about a week and a half of everything shutting down, we were up on virtual care and able to see our patients from home or from the hospital, however we needed to. And it really has made genetic counseling more accessible than ever before. Our counselors at Centura are able to see any individual located in Colorado or Kansas, and they can see us over the phone if they don't have computer access. They can see us over their computer, or in some places they can actually go to a facility and use a computer there. So we're really have been able to meet people where they're at, and we're not hearing any longer that we just don't have a genetic counselor near us, or the patient's not able to travel to get to you. We really are there and available to all patients throughout the state. And one of my favorite things is we've seen patients who normally would have canceled their appointment, or who normally would have not made the effort to schedule their appointment because they're busy parents or professionals. We're seeing folks during their kids' nap time, or busy professionals when they just close their office door for 30 minutes. So it's really made everything easier for patients to get this type of care. And it's Centura, I'll show you some charts here in a second. We actually had our busiest years ever in 2020, and then subsequently in 2021. So that, I think, is incredibly remarkable, especially since some of us had really limited availability during the first stages of the pandemic and weren't able to see patients all day. So first off, I'm going to show this chart here. These are our numbers at Centura for 2020 and 2021, just showing the incredible growth we saw, and that virtual care really made such a huge difference for our ability to see patients. And then this map shows by zip code the patients that we are seeing. It's not the whole state, but we're getting pretty darn close. All of these spots here that have any type of highlighting, we've seen patients from, which is really exciting. And I would like to see even more growth of that in the future. And then finally, there's just more demand and interest in genetics from the patient perspective these days. I know when I first started in 2009, I was going to tumor boards and practically having to beg for patients, saying, I think this patient would qualify, really try to get that patient to come. I'm very concerned. Now we have patients who may or may not have a cancer diagnosis asking for this type of service because they've heard about it or they've read about it. Everybody has probably heard about the Angelina effect that we saw after Angelina Jolie came out as saying she had a BRCA1 mutation. We definitely started to see an increase in patient volume then, but really we've seen a huge increase in the amount of recreational, it's what I call 23andMe and Ancestry genetic testing. And that has helped people to feel more comfortable with genetics. Now, obviously that's a very different level of testing. And we can talk, I can do a whole presentation about some of the pitfalls with that type of testing. But what I really do credit them with is getting people interested and more comfortable having those conversations about genetics. Genetic testing is also available for more conditions, and it's being utilized by more specialties than ever before. So people are hearing about it in different avenues, from cardiovascular care to ocular care and hereditary cancer. So they're just hearing about it more frequently. But the major problem is we're still not graduating enough genetic counselors each year to keep up with the demand for services. So that's something that we in the field need to continue working on. Many genetic counseling clinics do have wait times for a few months for routine appointments, but most clinics hold spots for cancer patients or patients making urgent treatment decisions. So if the information truly is something that we need in a timely fashion, in most cases, clinics are able to make that happen. And then finally, I would really push that even if a patient has to wait for an appointment for a few months, it is still worthwhile to make that referral and to discuss the importance of how this type of information really can change a patient's medical management and change the quality of their care as well. So some of the future directions our field, again, I think we need to prepare for genetic testing for all, not only all cancer patients, but all people interested in any type of proactive or preventative genetic testing. I say most GCs would like to continue implementing a model that includes in-person and virtual, but I haven't heard of any GCs who don't enjoy having that virtual option. It really has revolutionized what we're able to do, and we do hope that that stays as something that we have access to. And then we would like to see continued effort in how to get our services in the far reaches of our state. Since we can now see people over their phone just as easily as them coming to our centers, it's time to really make that push and make sure that every Coloradan, every Kansas folk, for those of us in Centura as well, is able to access the care if they would like to. And then something that would change things, I mentioned this earlier, there is a bill that we are trying to get passed nationally that would make genetic counselors recognized providers by Medicare. And if we are recognized as providers, they would then pay for the genetic counseling piece in addition to the genetic testing for appropriate patients. So I have some information there on if anybody would like to provide support for that. That is something that we would love to have. And we'll have questions here in a second, but I did want to put out a quick plug. Andy has heard me talk about this before. This video is absolutely incredible. It was put together by the health department and the University of Colorado genetic counseling team. This is little Gene here, and he explains hereditary cancer in a really, really great, simplified way, has a great accent as well, so everyone adores him. And that's something that makes this type of service a little more accessible to patients. If they are having questions or if they're wondering what this is all about, that's a great resource to have in your tool bag to just help explain this information to folks.
Thank you so much, Melissa. And we definitely have some great interest in the video. So we will send that out in the follow-up. But Melissa, if you have it handy and are able to put it in the chat as well, definitely some interest in people wanting to check it out right away. So we have about time for one question each for Andy and Melissa before we move forward for a quick break and then on to our next presentation. So a question for, I guess, both Andy and Donald is, as the screening rates recently lowered to 45 from 50 for colorectal cancer screening, what considerations or strategies do we need to consider with starting to get those people screened in addition to continuing our efforts for screening those 50 and older?
Don, I'll let you start.
Oh,
Look at us both pointing at each other.
I was going to let you start. I'll give kind of a broad answer and then get specific. Telehealth was invaluable during the pandemic, but what we've learned is our patients crave face-to-face interpersonal connection with their providers. So I think intrinsically, re-engaging patients just in general with their primary care home is where to start. Not necessarily colorectal cancer screening, but hey, come back in. Let's make sure you're up to date on all your health maintenance concerns. And then, I guess what I'm saying is get that relationship primed again. Not that all patients, we lost touch with all patients, but certainly that was a big fallout of the pandemic in our practice. I think most community health centers anyways around the state really contracted in terms of unduplicated clients served. More specifically, I think I would just revert back to the PDSA QI process, go back to the basics. How is your system performing now? How's it functioning now? Where's variation that you don't want, and then design some interventions that make sense for your particular setting and patient population.
Yeah, I agree, Don, with those as well. And I think that return to primary care helps all ships rise for that messaging. Now, specifically for the 45 to 50, what I would add is, there's a lot of variation in terms of health messaging and awareness and how we speak to folks based on their demographics. So where they live, where they play, where they work, or where we work, right? We're all patients. So I think for a 45-year-old up to the screening age of 75 and beyond, I think looking at those targeted messages that help motivate folks. And I think being aware that, a 40 or 45-year-old might have a very different lifestyle or day-to-day than a 70-year-old. So I think we need to start messaging and talking about colorectal cancer, probably in the early 40s. So that way we start the on-time screening at 45. Maybe we start doing that with more OBGYNs, more men's health and fitness, more discussion about family-based care to get people to start at 45. Part of the big, precipitous for even talking about 45, there was great data to start. But it's also sort of saying that if you at least start talking about it at 45, that people have the screening done by 50 years old, because at 49 to 54, that's some of the biggest rates. So making sure, but I think that iterative messaging, understanding who that population is, knowing that there's distinction from a rural versus an urban versus a 45 versus a 75-year-old, those are things that we're going to actually have to take into consideration. And I think we have to start, although some of the data I showed a little higher trends for men during a period of time, it's usually and typically historically an equal opportunity killer. So men and women, I think we have to stop saying it's an older person's disease. We know those trajectory, even in the young, it's a big deal. So I think we have to start talking about our bodies and kind of also really let that whole stigma piece go. So those are some of the considerations I would think, in addition to what Dawn said in terms of building clinical capacity.
And need to move on to Melissa in just a moment, but Dawn wanted to give you an opportunity for closing thoughts.
Yeah, real quick. This has nothing to do with answering your question. I just noticed that our case manager, Francisca, was just able to join the call, and I want everyone to know that she was the linchpin behind our improvements. Her caring way, her ability to communicate with patients has been invaluable. I think she had to join this call late, probably because she was helping her teammates out cover the clinic and do other things. So I just wanted to take my hat off to my coworker, Francisca.
Thank you so much, Donald and Francisca. It's been a pleasure to work with you for the CCSP program. I know you do so much to support your patients and have been really engaged with our program and the different opportunities for how to better support and improve those barriers that patients experience. So before we move on, I just wanted to turn it over to Melissa to give some closing thoughts. And I know you did answer a question in the chat about access to genetic testing and counseling for uninsured patients. So if you want to just say a couple words about some of those barriers and how we can help improve access for those that are lower income.
Right. And that has previously been something that has been a known issue. How do we get this expensive test to individuals who have no insurance coverage? Thankfully, many of our labs have patient assistance programs. So if a patient qualifies for testing and they don't have any type of insurance coverage based on their income levels, which are very generous, in the vast majority of cases, we are able to get that patient free or low cost testing. So again, what I always tell my physicians is go ahead and make the referral and let me figure it out. There are lots of avenues to get the appropriate patients appropriate care.
Thank you. Thank you so much for your time. And Andy also added in the chat a little bit about the capacity building work we're doing with CCSP. And then also at the University of Colorado Cancer Center, there's the CPCRN grant. And so that's another avenue where we're going out and working with different communities and healthcare systems to help increase that access as well. So without further ado, we are going to take a quick pause and then turn it over to Debbie Dyer for our next section on lung cancer screening. Welcome back, everyone. So our next presenter is Dr. Debbie Dyer from National Jewish Health, where she's the chair of the lung cancer screening program. So I'm going to turn it over to her to share a little bit about lung cancer screening in Colorado.
Hello, it's great to be with you all today. And I just loved listening to the other presentations. And I just admire that, for instance, with colon cancer, you're aiming for 80% because we're so far from that with lung cancer screening, but we're using you as a great model. So just briefly, disclosures, I am a consultant to Lung Ambition Alliance and a member of the Clinical Advisory Committee of a company, Imidex, and the GoTo Foundation Scientific Advisory Committee. So lung cancer, as most of you know, is the leading cause of cancer death in the US. More people die from lung cancer than from breast, colon, and prostate cancers combined. Survival is clearly related to the stage at diagnosis, and chest X-ray screening has not shown benefit. So this is what we're trying to do. We're trying to identify lung cancer at an early stage. The arrow's pointing to a small nodule in the periphery of the right lung versus the later stage where we have this large mass in the middle of the left lung. So the world of lung cancer screening really changed with the results of the National Lung Screening Trial in August of 2011. And this was a huge study, 53,000 participants, ages 55 to 74, multi-center study. And half the group was randomized to a chest X-ray arm and the other half to a low-dose chest CT arm. The patients received a baseline scan and 2 annual screenings. And it showed a 20% decrease in lung cancer mortality with the CT arm. And in fact, the study was stopped early because of this advantage of 20%. So going forward, since 2011, we did have the U.S. Preventive Services Task Force support lung cancer screening, and then eventually Medicare. But the good news was last March in 2021, the U.S. Preventive Services Task Force revised their criteria and they lowered the starting age to 50 and the PAC years to 20. And they gave screening, lung cancer screening, a grade B. And they also kept in place an upper age limit of 80, and they kept in place 15 years since quit if the patient had been a former person who smoked. They referred to this as the 50-80-20-15 plan. The benefits of this approach is it is thought it will help address the disparities in lung cancer screening. And for example, it will particularly increase the number of Black individuals, by about 107% and Hispanics by 112%, who are eligible for screening. And this chart from a wonderful article published in 2019, I think just gives a nice illustration of how the different racial and ethnic groups really experience lung cancer. And you can see in the orange that Black individuals do get lung cancer with lower smoking exposure, so lower pack years, and also at younger ages. Now, the Medicare NCD, which was just released this past February 11th, did in fact change their eligibility requirement as well. We had hoped that they would align with the U.S. Preventive Services Task Force, and they almost did, shall we say. So they did drop the age to 50 for starting lung cancer screening, but instead of an upper age limit of 80, for Medicare, the patients have an upper age limit of 77. They did drop the minimum pack years to 20. They kept in place that a patient has to be currently smoking or quit within the past 15 years. Patients have to be asymptomatic with no signs or symptoms of lung cancer. And typically we consider those to be hemoptysis or coughing up blood or unexplained weight loss. And then Medicare still does require an order. Okay, here we go. And interestingly, they also reevaluated their requirement for a shared decision-making visit. And lung cancer screening was unique in that Medicare required a shared decision-making visit be performed before the CT as a condition of reimbursement. And this had to be done by a licensed provider. So a physician, an NP, a PA, or a clinical nurse specialist. And that was limiting. So, I mean, for a lot of reasons, it was limiting. And certainly it took a lot of time from the physician's schedule to have to do this shared decision-making just in order to order the CT. So what Medicare did in their revision to their determinant this past February is they kept the requirement for shared decision-making, but they said it could be performed by auxiliary personnel incident to the physician's professional service. Now, there's a lot of detail to be worked out here, but essentially a physician in their private office can delegate this shared decision-making to someone in their office. It doesn't have to be a licensed provider, but they have to understand what they're talking about clearly. And they can do the shared decision-making, and then the provider can sign off on it and order the CT. A decision aid is still required. It's still important that patients adhere to annual screening and that patients be offered smoking cessation counseling or certainly encouragement to maintain smoking abstinence. And then very importantly, this was described earlier as a silver lining to the pandemic, is that the shared decision-making visit can be done by telehealth. The other thing the new Medicare coverage determinant did is it simplified the reading radiologist eligibility, eliminating some of the minimum requirements, but it did keep in place that the radiologist has to be board certified or board eligible. And then importantly, it changed some requirements for the imaging facility. It kept in place that the radiologist needs to use a structured reporting system, such as LungRads, but it eliminated the requirement that the facility report the radiation dose It eliminated the requirement that smoking cessation intervention be offered. So now CTs can be performed at the independent diagnostic testing facilities. And it also eliminated the requirement for participation in the CMS approved registry. It is still encouraged to have programs report their data to the registry, but it's no longer required as a condition of reimbursement. This is what lung RADS looks like. This is what the radiologist uses in interpreting the CT and establishing recommendations for follow-up. And I'm going to zero in here into the category called lung RADS 4. These are considered positive exams, and the nodules or the findings would be suspicious or very suspicious for lung cancer. And you can see here that there's basically size criteria and then recommended actions for next steps. And the recommended actions, once you get to this lung RADS 4 category, is usually doing something like at least a short-term CT in 3 months, or for more suspicious cases, PET CTs or biopsies. And here's an example of how lung RADS works. So a patient came in and had a screening CT. This is an image of their lower left lung. And this patient had this pleural-based nodule, and there's some solid components centrally and kind of this halo of ground glass around it. This, by the lung RADS criteria, is a classification 4A, and this is a recommendation for a 3-month follow-up. The patient came back and noticed that the nodule now looks bigger. There's much more of a solid component. So now this becomes what's called the lung RADS 4B, and immediate action is recommended here. So this patient did have a biopsy, and this turned out to be an adenocarcinoma, early stage, stage 1. It was resected, and the patient is considered cured. Now, insurance coverage then for lung cancer screening, in summary, it's ages 50 to 80 for commercial insurance and Medicaid. It's age 50 to 77 for Medicare. And we talked about the minimum 20-pack year history, currently smoking or quit within the past 15 years, no signs or symptoms of lung cancer, and a patient does need to be able and willing to pursue curative therapy. It doesn't have to be surgery. Radiation therapy is certainly an option. So lung cancer screening is covered as a preventive service by commercial insurance, Medicare, and Colorado Medicaid, with no copay or cost sharing for the screening exam. Pre-auth is required by most commercial insurance and some Medicare Advantage plans. No pre-auth is required by traditional Medicare or Colorado Medicaid. Now, the timeline for the new coverage criteria, the age 50 and 20-pack years, is a little bit in flux. Most commercial insurance companies have adopted the new criteria. As I mentioned, Colorado Medicaid has fully adopted the new criteria, and Medicare just released their determination in February. It is effective as of February 10th, but the local Medicare contractor is allowed to hold the bills until a local coverage determinant is established. So right now, if a screening program wants to have patients come in, and Medicare patients at 20-pack year history of smoking, they can certainly do the exams, but they may not get paid right away. Now, the other thing that's very important to consider with lung cancer screening is that there's a lot going on a CT. And certainly we're looking for suspicious nodules for potential early stage lung cancer. And in most lung cancer screening programs, it is really a team of people that make this work. And programs either have to have a navigator or coordinator up front to make sure that the right patients get screened. And then many programs will have advanced practice providers that help ensure communication of results to the patients and make sure that appropriate follow-up is ordered. If there are suspicious nodules, a multidisciplinary committee is recommended to discuss and review the case and make recommendations back to the referring provider about next steps. If a program is in a facility that doesn't have access to this multidisciplinary team to do these reviews, then they need to have at least some sort of referral network in place for the advanced workup and the care escalation. And then finally, very important in lung cancer screening, we do find other things. We find incidental findings of thyroid nodules, renal nodules, liver masses, aortic aneurysms, other lung disease. And so there really has to be a system in place so that the referring provider understands what the recommendation is if any of these other findings are found. And I can tell you, certainly, I know program coordinators at every lung cancer screening program, and it is not at all uncommon for programs to find thyroid cancer and renal cancer. And so we really, really have to make sure that we do our due diligence and get these incidental findings followed up on. The current state of lung cancer, unlike others, goals of 80% right now in Colorado, only about 3.3% of eligible Coloradans are getting screened for lung cancer. We expect that that number is even going to increase higher in the eligible patients now that we have the task force recommendations and Medicare coverage for the lower age and 20 pack years. Also of concern is we know there's suboptimal distribution of lung cancer screening centers in Colorado, with rural and underserved populations not getting screened, even though they have higher smoking rates. And then there's a problem of steerage of patients by insurance companies to low-cost imaging centers that don't have any lung cancer screening infrastructure. Now, if they have infrastructure, that's terrific, but it is really a problem to just have an insurance company send a patient to some random imaging center for a lung cancer screening CT when there's really no infrastructure. So there are numerous barriers. We have been working on these over the past several years. I've certainly had the privilege of working with the CCSP program and trying to address some of these concerns. We know we have complex eligibility requirements. There's a written order requirement. There's a general lack of patient and provider awareness. Shared decision-making visit is required by Medicare. We have overburdened primary care providers. Hopefully with the new Medicare approach of allowing auxiliary personnel and physician offices to do the shared decision-making, we might be able to help there. There is still the stigma about smoking and patient nihilism. There's a general lack of access in underserved areas. And then, of course, there's financial barriers. Some patients have high deductible plans. This shouldn't influence their ability to get screened, but if they need any follow-up testing, they will have copays. And with the high deductible plans, those copays can be significant. There's always transportation costs, the need to take time off of work, and then the issue of coverage for uninsured. So challenges with the new eligibility requirement criteria, we know there'll be more and more persons eligible, and we have to figure out how to educate and engage them. Adherence to annual lung cancer screening is low, ranging from 16% to maybe up to 45%. We need to do better at getting patients to come back each year. This is one of those places where navigators are worth their weight in gold, because they can be part of that approach to remind patients and get them back in. And then, of course, uptake of lung cancer screening, as I mentioned, is lowest in some of our highest risk populations, those within the lower socioeconomic groups, rural areas, the LGBTQ community, patients with mental health disorders, and how do we reach these folks? And I just wanted to share with you this chart. I think this is fascinating. Our lung cancer task force within the Colorado Cancer Coalition has done now 2 queries of the Colorado all-payer claims database. And we looked at where is the utilization of lung cancer screening highest, where are our highest needs. But one of the questions we also asked the all-payer claims database was, what are the comorbidities of patients that come in for lung cancer screening? Well, no surprise, the respiratory system was the highest, but number 2 was patients with mental and behavioral health disorders. So that's a whole population of folks that I think we haven't targeted. We haven't really thought about how to reach them. And one of the things that we're considering is, wow, we need to engage and educate the mental health providers to encourage patients to come in for lung cancer screening. So in summary, the new task force recommendations and the Medicare coverage decision will help address disparities in lung cancer screening and considerably increase the number of eligible patients. Structured reporting with lung RADs allows for consistent reporting and lung nodule management. Disparities in the distribution of lung cancer screening centers are out there in our rural and underserved areas of our state. And then the barriers to lung cancer screening are significant. But I think by working with groups such as this, we can help address some of those barriers. So thank you. If anybody ever wants to reach me, here's my email, and I'm happy to take questions when we have time for questions.
Awesome. Debbie, thanks a million. And I just want to also remind everyone that CCSP right now is doing some great capacity building. And Debbie is one of our foremost experts. It's been a great partnership with her, Pearl Ann, their team. And we do have some opportunities for continued collaboration this way into the next year as well. So Debbie, a million thanks. And, you know, I was really excited, even at the CCPD review committee meeting, we're getting some strong support for lung cancer screening. And I think that this is an area we have a lot of work to do. And you're right, you know, colorectal learned a lot from breast. You know, lungs learning, and we're trying to really think about these comprehensive navigation approaches, which, you know, I do love that you just did that highlight and that shout out to navigation, because colorectal, some of the lowest rates are amongst the same population still for lung. And even though they're still in single digits, I think that's going to remain germane throughout the work. So a million thank you for all the great work. We're going to go ahead and switch gears, and I have the honor to introduce Dr. Richard Goldberg, who I actually shared is going to be a panelist and a discussant today. I've had the great honor of working with Rich with Fight CRC in terms of really thinking about prevention, early detection, but also thinking about what are those areas that we're doing to really think about path to a cure, and what are we doing in terms of looking at treatment options, quality of life, survivorship throughout the continuum. So given we are in colorectal cancer awareness month in general, I think it's really helpful for us to talk about the continuum and some of the priorities that are moving ahead that I think are setting some of the national agenda work. So Rich, thanks a million for joining us today in Colorado. I know you're a national guy. You've done a lot of clinical work, but one of the things I just have to say, everyone, about Rich that I just love is, as much he's worked on developing a number of treatments in the pipeline, really kind of a foremost leader in terms of thinking about therapeutics and the like. What I always love about Rich is when we talk about colorectal cancer, he just reminds everyone that cancer prevention is still key and paramount, and we can make some of the biggest impact by doing prevention, screening, and early detection. So Rich, thank you for all of the great work. And I think it's been great to have a champion who really sees the whole continuum. And I know you're a great Fight CRC board member, and you're going to be sharing part of that work today. So Rich, I'll turn it over to you.
Okay, thanks, Andy. I'm having trouble sharing my screen, so I'm hoping one of you can pull up my slides and help me change them as we go along.
Absolutely. Elsa, do you have those slides ready to go? I think you could
Yes,
probably.
I
Okay,
will pull them up.
awesome.
So I'm going to talk about fight colorectal cancer. And just to give you a little background while we're waiting for the slides, this is a group that was put together by Nancy Roach, who is a cancer survivor herself, as an advocacy group. And one of the things that Fight Colorectal Cancer strives to do is to convene the various stakeholders who are interested in colorectal cancer. That's first and foremost the patients, but also their caregivers, and those of us who provide care to those individuals as well. So it's a diverse group of people, and Fight Colorectal Cancer strives to convene them. And one of the things that's an outcome of our convening is this Path to a Cure report. Next slide, please. So the Path to a Cure is something where we looked at indicators of progress, tried to figure out what are the key messages that this community of scientists, patients, and their loved ones want to communicate to each other, to physicians, to politicians, to funders. What are the opportunities and challenges that we face? And always as a patient advocacy group, we have to keep in mind survivors' voices. And I would say one of the greatest things I've learned by my association with this group, I've taken care of thousands of people with colorectal cancer over my life, is, I'll tell people, well, when I started, we had one drug, now we have 15, we've made great progress. The survivors say, we sat next to people in our treatment rooms who die of colon cancer. We're not satisfied yet. You have more to do. Next slide. So what are the key messages? Well, prevention, prevention, prevention. There's no substitute for it. What I can do in treatment doesn't substitute for what you can do for your patients in primary care settings to get them to the colonoscopist, to have their pre-malignant polyps removed and to catch their disease early. So early detection and prevention is the key. We also find that as we talk to young people, that many of them went time after time to primary care doctors with symptoms. They were told, you're 25, you're 27, you can't have colon or rectal cancer. And of course, some of them did. We're interested in supporting innovative research. We've made progress, but we're impatient to make more progress. And of course, for those people that do have colon cancer, quality of life beyond diagnosis, treatment, and surgery is particularly important now that we're curing more and more people, and they have to put up with the sequela of the treatments that brought them to cure. Next slide. So our Path to the Cure report has four main areas: biology and etiology, prevention and early detection, treatment, and survivorship and recurrence. And we've gone through and tried to identify progress indicators. So for biology and etiology, you heard about hereditary colon cancer risk. I'll talk about that in a moment. Cancer prevention and early detection, can't emphasize that enough. Expanding treatment possibilities, and then of course addressing quality of life. Next slide. So under biology and etiology, we have identified four different objectives. More research into the nature and biology throughout all ages, impacting health disparities, genetic and hereditary cancer, and particularly one kind of hereditary cancer, Lynch syndrome, a syndrome described by Henry Lynch, who was an investigator with a long career at Creighton University, who identified the fact that some families inherit a predisposition to colon and uterine cancer. Next slide. So let's think a little bit about prevention strategies in biology and etiology. And there are some incredibly high-risk groups of patients. The ones that are most notable are those patients with this inherited Lynch syndrome who have a 17-time higher rate of developing colon cancer than the rest of us. So think about it. 1 out of 25 men or women in the US will develop colorectal cancer. For Lynch syndrome, it's 17 out of 25 will develop colorectal cancer. Ashkenazi Jews have a higher incidence. Indigenous people relevant to you in Colorado. Colorectal cancer survivors are now 1.5 million of these individuals in the United States, and they have a higher risk of colon cancer. African Americans and rural populations. And we talk a lot about people under 50 years old. They actually have a lower incidence than the average person, but that incidence is rising. Next slide. Now, this is a study that we did when I was at Ohio State that showed that in a group of 450 people from Ohio, when we tried to do a population-based study, 1 out of 11 of the patients that we investigated who had colon cancer under the age of 50 years had Lynch syndrome. 1 out of 12 had another hereditary cancer syndrome. As was mentioned, some had breast cancer, BRCA or BRCA1 or 2 mutations. And as a consequence, if we put it all together, 1 out of 6 of these young individuals had at least one hereditary cancer syndrome. Next slide. So we don't do universal Lynch syndrome screening in the United States, although it's done in other parts of the world. But if you were to say in 2016 that there were 135,000 people that were diagnosed with colon cancer, 3% of them, or about 4,000, would have had colon cancer. If we screened all of these patients, we would have been able to identify 12,000 of their relatives, 3 per patient, that had Lynch syndrome. If we took all patients with endometrial cancer, the other high-risk cancer for individuals with Lynch syndrome, we would have identified 1,800 other patients with Lynch syndrome and 3,600 of their relatives. So by doing universal Lynch screening, we would have identified over 21,000 people who would have needed special screening to be done because they have a 75% lifetime risk of developing colon cancer. Next slide. Now, when we look at patients under 25, patients with Lynch syndrome are more likely to get young onset colon cancers. We find that their lesions are more likely to be advanced T2 rather than T1 in older patients. They're more likely to have peritoneal cancer, which is a more deadly form of colon cancer. They're 4 to 6 more times more likely to die of colorectal cancer. And 10% overall survival at all stages. Next slide. So now let's turn to prevention and early detection. We want to improve dissemination and implementation of colon cancer screening in the average risk population. That's what you and primary care practices are working so hard to do. We want to also get testing to high risk and symptomatic populations to deal with early onset colorectal cancer and to develop minimally invasive strategies for preventing colorectal cancer. Next slide. Next slide. So, as you know, there are a number of different ways that are approved to test for colon cancer. Fecal occult blood testing is perhaps the easiest, and randomized clinical trials have showed a mortality reduction of 20 to 33%. Next. Flexible sigmoidoscopy does a little better than fecal occult blood testing, but of course, it only detects colon cancers in the left side of the colon. Next. Colonoscopy does a better job. It's not as good at right-sided detection as it is at left-sided detection, but it remains the gold standard for the moment. Next. Now, this is an interesting interesting study that was just published as a letter to the New England Journal of Medicine that Kaiser did. And what Kaiser did was they proactively mailed fit tests to patients, whether they asked for them or not. And on request, they would do colonoscopy. They enrolled almost 100,000 Blacks and 700,000 whites. This was done between 2000 and 2019. And what you can initially see here is that the Black patients who are in the orange graphs in each of these 4 graphs initially had a higher incidence of colon cancer because they had to catch up. But once this program had been in effect for the 19 years, the mortality and incidence of colorectal cancer came down and was equal between Blacks and whites. And we're actually doing this in a research in a number of other states now. Next slide. What about the promise of blood-based cancer screening? Next. All right, so there are a whole bunch of companies, Gallery, Guardant, Exact Sciences, that are looking at markers of cancer in the bloodstream so that rather than having to have a colonoscopy or do a FIT test, we can screen not only for colorectal cancer, but for many different cancers with a single blood test. And there are huge scale studies being done, such as the GRAIL partnership with the British National Health Services, where they're screening 150,000 patients over the age of 50 for these multiple cancers. I believe this technology is going to change our world in the future. Next. So what about prevention? Well, this is a study that modeled the likelihood of preventing colon cancer in middle-aged men if we could get middle-aged men to have an ideal body weight, exercise, take a multivitamin with folate, limit their alcohol, not smoke, and limit their red meat. Next slide. So this describes 3% of all men in the US today. Next slide. But if we could do this across the board, we could, it is estimated we could eliminate 71% of all colorectal cancer. So prevention is possible, although not easy. Next slide. Now, this is a new screening technology of circulating tumor DNA for patients with cancer that shows that in patients with early stage colon cancer, on the top line are the patients that never had circulating tumor DNA detected in their bloodstream. In the purple line are the outcomes of the patients that did have circulating tumor DNA found. And you can see that the curves are dramatically separate. This would allow us potentially an early detection mechanism where we could intervene once this technology gets further defined. Next slide. What about treatment? Well, we're interested in increasing treatment enrollment, doing more biomarker and molecular testing, designing patients with individual sequences for their therapies, strengthening infrastructure design, and increasing federal funding. Next slide. So what about the potential of biomarkers to guide precision therapy in colorectal cancer? Next slide. So there are a bunch of studies that we already are doing. One is the marker for Lynch syndrome and other inherited or acquired syndromes where patients have a defect in their the spell check that allows them to repair DNA when errors in DNA are made. There are several other biomarkers that are also important. Next slide. To show you why the first one, microsatellite instability, is so important, this is a graph generated by a study that we participated in when I was at Ohio State, using the immuno-oncology drug pembrolizumab in patients with mismatch repair defective cancers that could be identified by doing a genetic test. And the green line is the patients who are treated with the new agent who had mismatch repair deficient tumors. And you can see that these were patients with advanced disease, and at 24 months, no more of them died. So this was a curative therapy for advanced disease. Unfortunately, it only applies to a small minority of patients, and we're looking for treatments like this that are going to be useful in larger subsets. Next slide. The trouble is that many oncologists are not doing this testing. This was a study done by Flatiron Health across 13,000 patients ending in 2017, showing that the majority of patients were not being tested for these critical genetic markers. Next slide. The last thing I want to talk about is funding. And here you can see that the National Cancer Institute has a big budget, $5.9 billion in fiscal year 18. But you can see in the little purple bars, deep purple bars, that funding for colorectal cancer research is relatively small, especially considering it's a second leading cancer killer in both men and women. Next slide. Other potential funding sources for research, the National Cancer Institute, the Department of Defense, the ARPA-H program that President Biden is pushing, Stand Up to Cancer, foundations, and collaborations with industry. Next slide. Finally, survivorship and recurrence. Developing survivorship research, increasing the capacity of our health delivery systems, and improving research efforts for getting new technology tested and proven. Next slide. And of course, universal healthcare access is really critical. It sounds like perhaps you in Colorado did not expand Medicaid. We did in West Virginia, and it's been critical to us. Despite the expansion of Medicaid, colorectal cancer results in huge amounts of out-of-pocket costs for patients. And I saw a study just today that shows that 71% of patients diagnosed with colorectal cancer, regardless of their insurance status, incur additional debt in their first year after diagnosis. Next slide. So finally, just to summarize, biology and etiology, prevention and early detection, treatment, survivorship, and recurrence. These are the things that we are working on through Fight Colorectal Cancer, talking to our people on Capitol Hill about increasing funding, talking to the head of the National Cancer Institute, talking to drug companies, talking to patients and caregivers, and talking to you as well, because you guys are the boots on the ground that really make a difference in terms of prevention and early detection. Next slide. So everyone has a role to play. We're setting priorities. You can set priorities. You can host an annual dialogue, establish criteria for progress, update stakeholders, select policy level interventions, and put pressure on implementation. We've got to do this together if we're going to make progress. I think that's it.
Thank you so much, Dr. Goldberg, for sharing that full spectrum that Fight CRC is concentrating on. We really need to look at colorectal cancer holistically from every angle if we are going to lower those incidence and mortality rates in all ages, especially those who are getting diagnosed at a younger age. And just want to say a big thank you to everyone who's been able to stay on for the call. I know we've been gone over a little bit of time, but it's really important information. And Rich did a really nice job of tying in, of course, some of those important messages that Melissa had shared earlier about really the importance of looking at hereditary risk for colorectal cancer and Lynch syndrome, in particular for both prevention as well as treatment options. So if everyone is anyone's able to stay on for just a couple more minutes, we will give the opportunity for both Debbie and Rich to answer a question. So starting with you, Debbie, I'd love for you to share a little bit about some of those opportunities for people who are just starting to think about how they can increase or start doing referrals for lung cancer screening in primary care if that's not an area that they've been currently focusing on. What are some of those initial components for navigators or others in the clinic team to start thinking about to better get access to patients to lung cancer screening?
So and that's a very good question from the standpoint of, I think if it's a clinic setting, it helps to just identify someone as a point person to keep track of who might be eligible, who can be offered the screening. If you have an EMR, you can have the EMR kind of help query patients who have longer smoking histories. But if it's in a setting where it's maybe a bigger practice, and if you have any sort of coordinators for research, you could borrow some of their time. And that's how we started. We, years ago, we just borrowed some time from one of our researchers for an entirely different study, but you kind of figure out kind of what you need. And the bottom line is you need a coordinator. You need somebody as a navigator coordinator to get it off the ground. And then, you know, everybody has to start with probably Excel spreadsheets of just tracking patients, but eventually you need something a little more sophisticated than that. But I think those are keys to identify a point person who's going to kind of push it along and do the day-to-day work. Of course, there needs to be some sort of professional champion as well. And if it's a multi-group practice, at least one of the primary care providers, if they could be a champion for it. It just can't be done by one person or one entity. Radiology cannot do it by itself.
Absolutely. Yeah, it really is that team-based effort, and having those champions to get the momentum going is really so important, as we're seeing with many of our CCSP clinics, including Keefe Memorial, who's really taking that leap to start to implement in their health system. So for those of you who are interested in learning more about lung cancer screening, we're going to have a longer presentation by Debbie, really diving into some more of those implementations components in early June. So we'll be sending out the information about that, and we hope that you all will join us for that. So thank you very much, Debbie. For Rich, there was a question in the chat of, do you think that more money will be diverted to CRC screening when there's new advances that emerge for people who are or underinsured and low income?
I'll answer that in a minute, but I first wanted to talk to Debbie and say that this summer we implemented our mobile lung cancer screening bus called Lucas.
I've heard about
for
that.
Lung cancer screening in West Virginia, and we face the same issues in West Virginia that you do in Colorado, and to a lesser extent in Kansas. Getting into the hills and mountains to get people screened. We found that it was a magnet for donors, and we didn't have to pay for it.
Excellent.
Because donors paid for it. So consider trying to sell that to your development office.
All right, good advice.
So with regard to these new screening tests, I could talk for an hour about new screening technologies, including the test Cologuard that you've all seen advertised on TV, which is a DNA-based assay for genes in the stool that are markers of colon cancer. There are going to be a whole bunch of new tests that are going to come out, some of which will be much easier. It may be that we'll be screening for lung cancer, colon cancer, uterine cancer, et cetera, all with one blood test. And that will probably make screening more accessible and more acceptable to patients. But one of the things that Fight Colorectal Cancer does, we just had a Hill Day where we went and lobbied with your congressmen and ours and your senators and ours about the importance of screening and early detection. And those are the ways that we're going to get more coverage for the tests that can make such a difference.
Yes, it's very exciting about these new blood-based tests for colorectal cancer individually, and really looking at testing for or looking at multiple cancers and being able to screen with just one test. So really excited to see where the technology goes. And it's a really great point that we can all be advocates for increased funding and reaching out to our legislators about this importance and need for colorectal cancer to have continued focus and dedication with these increasing and rising rates in younger adults. So for everyone who's still on, I did put in the chat a link to the Fight CRC Path to a Cure report. So if you're interested in diving in more to each of the 4 areas, there's a really nice interactive opportunity on there to look through all of the components of the report. So I just wanted to give another big thank you to Dr. Dyer and Dr. Goldberg for taking the time to join us today and sharing a little bit about where we're going with lung cancer screening and colorectal cancer screening. And a big thank you to everyone else who is involved in today's meeting. Andy and Melissa as well for sharing some more about colorectal cancer and hereditary cancer risk. So with that, I will let everyone go. I know we did take up a little bit more of your time today, but it's really important information. And we will be sharing all of this out with you all with the links to all of the slides and information to explore further. So thank you very, very much, everyone. And I hope you have a wonderful rest of your day. Take care.